There is an eye condition that is called keratoconus, and it is a very important condition because it affects young people. And today I've got Dr. Bongi Mofokeng, who is a qualified ophthalmologist who's working at Charlotte Maxeke, Johannesburg Academic Hospital. She has a special interest in corneal surgery. And corneal conditions, but also in pediatric ophthalmology. So I'm glad to have her on the show with me today. This is the Dr. Tev Show, where we're putting your health back into your hands. Hi, Dr. Mofokeng, how are you?
I'm good. How are you, Dr. Tibbs?
I'm good, thank you. Thank you so much for joining me today.
Thank you for having me.
Yeah, so I want to ask you, about the keratoconus. But before we get there, can you just explain about the cornea? What is this function and what does it do? Because that's what's really affected by this condition.
Okay, so the cornea is like a window, right? It's transparent. It's the front covering of the eye, right? And what it does is it's responsible for bending most of the light when you're looking, so that when all the light rays come into your eye, they're focused well and crisp onto your retina, and they give you a nice clear image. The lens also bends the light, but the cornea does most of the bending of the light, so that when you look at images, it's clear, it's crisp, it's well defined. So that's the one thing. And for the cornea to do that, it has to be clear. It has to be transparent. It cannot have fluid inside, but also the shape. The shape of the cornea is what allows it to actually bend. So it acts like a lens. You know, like now we have cameras. Cameras have lenses in them that take an image and they focus the image nicely and produce quality pictures for us. Even on our phones, we have lenses. Your eye actually also has different lenses, not just the lens that gets a cataract, but your cornea also acts as a lens because it does what we call refract, bend light.
Okay.
Yeah, so that's the big thing about the cornea.
Brilliant. So tell us, what is keratoconus?
So keratoconus, you know, the name sort of explains it. It's
Okay.
like a cone. Kerat is cornea, and then cone is like a cone. So normally your cornea's shape is like, you know, when you take a rugby ball,
Yes.
and you put it on its side, not like this, but you put it on its side.
This way.
Yeah, it has this kind of a shape.
A curvature,
almost
yeah.
a oblong
Yes.
curvature. There's a reason for that shape, because naturally your cornea is a bit thick at the end and then it thins towards the center.
Yes.
So that it bends the light rays that are coming at the center less than the ones at the edge. And that's all done so that you get a nice crisp image. But now in keratoconus, the problem is that shape is no longer like that. It now becomes like a cone, almost like you turn the rugby ball up on
upwards.
its side, and now it's like a cone.
Like that.
Yeah, like a traffic cone or an ice cream
Yes.
cone. So it's so steep at the edge, you know, it's so thinned out and so steep at the edge. And then it goes down like this instead of having a nice smooth. So all of that, it becoming a cone, affects the way the light rays get bent. So obviously now at the tip, it's so thin, too thin. The light is getting bent. It's not coming together nicely. It's all scattering all over the place. And then the patient sees a blurred image. So that's really keratoconus. It's basically the cornea's shape having changed and becoming like a cone. Yeah.
And who normally gets this condition?
So we suspect there's some genetic predisposition, but there isn't a gene that has been successfully isolated and they say this gene is the one that causes it. There is an element of family history, so some people can say in their family someone else had it, but a lot of times you see patients who have eye allergies.
Yes.
And who rub their eyes a lot, you know. Patients who have ocular allergy or allergies when they're adults. So we divide them into two. There are those who get allergies as kids that is very seasonal. You know, in winter it's not so bad. Springtime it's really bad. It's usually the people who also get asthma, they get a runny nose, they get what we call allergic shyness, they get eczema on their skin. They're always rubbing their eyes all the time. All of that rubbing just worsens that cone, you know, it starts looking like this instead of having that kind of a shape. So those are the people. Some of them are adults. Like I said, most of the ones we'd see are children
Yes.
and teenagers.
Teenagers, yeah.
But adults can also get it. Some adults have ocular allergy where they just rub their eyes a lot because they're itchy, irritating, burning feeling. We call that adult onset ocular allergy. They can also have that. They can also get it. But a lot of the keratoconus patients are usually young due to allergy. Some of them can have systemic problems like what we call Ehlers-Danlos, other collagen diseases, but that's a bit rare.
Yes.
It can happen if you have a collagen problem because your cornea is made up of collagen mostly.
Yeah.
Yeah.
Okay. All right. No, that's cool. So now they've explained that very nicely. So what would this person complain of? So like the child, you've got a 15-year-old, 13-year-old. When they start complaining, how do you know that actually this could be keratoconus?
So normally they'll come and they'll say, I can't see well. The vision's blurry, you know. They don't always come and say my eyes are itching because you know it's easy to ignore this, doing this all the time, you know. We do it as well, like ever so often you do
just,
this, and in a child they feel like it's normal, you know. But a lot of times either the teachers will write a note and say your child's not doing well at school, or the child says like I have to sit in front, but even with my glasses, a lot of times it's even with my glasses I can't see and I sit in front, the images are just blurry, you know, and that's caused by all the astigmatism. The astigmatism meaning that the light is not focusing together as one. It's all splitting and splaying,
scattering all over the place. Okay, so now like, how do you treat this condition?
So it depends where the patient is. So normally when the patient comes, they either be referred by an optometrist or they come directly to us or from a local clinic. It depends how bad the keratoconus is. So what we normally do, we'll do a full eye exam and then we do what we call a pentacam or a topography, rather, let me say topography map. So that sort of, it maps out the cornea for us front to back and how it looks. You know, nowadays they have advanced things like epithelial maps where you can see keratoconus even earlier before you do like a topography. So an epithelium, that's the topmost layer of the cornea, just under the tears. There's a layer of the cornea called the epithelium. So changes in that layer already can tell you this patient probably has keratoconus, and you can start picking it up even earlier. So what we'll do is that we'll normally do 2 of these scans. And then we'll also do what we call refraction, like a glasses test basically, and see how well the patient improves. If the patient is progressing, so it means the keratoconus is getting worse, a lot of times glasses won't help because they have astigmatism, you know. What we'll then do is that we'll either offer the patient what we call cross-linking, that's to strengthen the cornea.
So what exactly do you do with cross-linking?
So cross-linking uses oxygen, it uses light, and it uses, we put a lot of tears in the eye, and we use vitamin B. To put into the eye.
So it's like eye drops into that.
Like
so the patient is basically lying down, and you put the eye drops in like the local anesthetic, and then you put these vitamin B.
Yes, we put we put like vitamin B. Different types. Sometimes we put some to make the cornea thicker, because with keratoconus it thins out. Like I said to you, think of a cone, it just becomes thinner and thinner and thinner. So the cornea actually thins out. So sometimes before we do the cross-linking, we sort of thicken the cornea a bit with the vitamin B, and then we apply the lights. And with the light there's oxygen obviously and some drops. And that strengthens the collagen bonds. It's to strengthen the cornea. Because if you leave it, keratoconus progresses into the 30s. Say the child comes when they're 12, it can go on until they're 35. By that time, it's so thin that it perforates. It forms like an ulcer.
Like a little,
it forms like a little ulcer there. And then there's a scar. Sometimes the innermost layer tears, and then the fluid in the front chamber of the eye goes into the cornea and causing it to swell up. It becomes white. Now there's a scar. The vision is worse. You know, it's just like this roller coaster. Now the patient has to get a transplant because their cornea is basically gone, which is a very, very important structure in the eye. So what we do is then we do this cross-linking. But before we do it, we have to see on the scans that the patient is getting worse. We don't do it if we haven't demonstrated that, because it comes with its own risks.
Yeah, what are these risks?
So the risks are patients can get an ulcer from the procedure.
Yeah.
A lot of times we remove that epithelium I was talking about, the topmost layer, we remove it so that the light can actually get to the collagen. A lot of the collagen is in the stroma, the thickest part of the cornea.
It's like a cake, basically.
Yes,
the cake is like a
cake.
cake. So there's the epithelium and the stroma and the innermost layer called the endothelium, just for simplicity. So what you're doing is you're removing the icing or the top layer of the cake. And then
we put the light so that the
Nice.
collagen strengthened, and it
Yes.
stops the disease from getting worse.
Yes.
But now that stops the disease from getting worse. It doesn't necessarily make the vision better. So normally what we'll do then after that, we can do what we call scleral lenses. Scleral lenses help us a lot in patients who have corneal scarring to help smoothen that surface. You know, I told you the surface becomes irregular.
Yeah.
So now you need something to make it smooth so that the light comes and it focuses on one place again. So we can do that. Scleral lenses, if the glasses are not helping the patients. It's a special type of lens. It's fitted in specially to help with that smoothening of the cornea. And then, like I said, other things, if it's really, really bad and severe, like if a patient has what we call hydrops. So that basically means in that cake, you've got the icing, the epithelium, you've got the thick part, then you've got the innermost part. We call it Descemet's membrane and the endothelium. If there are tears in that bottom part, the fluid that's in the anterior chamber of the eye can go into the cornea. Once that happens, it's really, we normally don't do the cross-linking then, because the cornea is already so weak. But now the patient will have a scar.
Yes.
So we'll either opt for a scleral lens over the scar, or we go to what we do, transplants, when we do the cornea transplant basically, because that part has now been damaged.
Sure.
Yeah, so it's like a series of things.
Yeah, so in a nutshell, from what I'm hearing is that keratoconus is a very serious condition.
Yes.
And it needs to be identified, because early on, the treatment is much easier than waiting later, and there's complications and so forth.
Yeah.
So the risks, the benefits of the cross-linking definitely sound like they outweigh the risk of just a corneal ulcer,
Yeah,
you know?
no, the cross-linking works well. And nowadays, they're developing technology where you can do the cross-link at the slit lamp. You don't need to do it in theater. There are machines where you can do it at a slit. That's the machine in the clinic, in a clean environment,
Nice.
with the patient sitting up, and you shine the light, and you can put the drops. You know, you can do it like that. That saves the patient also cost of going to theater, lying down, and all these things.
Okay.
So the cross-linking really, it's really changed the way we treat keratoconus. One of the other things I didn't mention, which is very important, you have to control the cause. If it's allergies in the eyes, it needs to be treated and controlled, because there's no point cross-linking, scleral lenses, transplant, blah, blah, blah. But the disease that caused it is not
Still
dealt
there,
with.
yes.
So that also needs to be dealt with. Yeah.
Oh wow! Oh wow! Sure. So in closing, Dr. Mofokeng, what would you say to the viewers about this condition?
So I think if your child has itchy eyes or ocular allergy, or you guys have a family history of keratoconus, you know, please get their eyes checked. You can go to your local clinic. You can tell the sisters, ask them for a referral, or the doctor's there. My child has itchy eyes. They're always rubbing the eyes. Get a referral later and come early. And by the way, the itching, we have remedies for that. I mean, now they have these fancy little eye packs you can sleep with, you know, that just reduce that urge of wanting to scratch. Some people use simple iced tea bags or whatever it is. They put it over the eyes just so that it reduces that, you know,
itchiness, that rubbing.
And also that wanting to just do this.
Get in there.
Yeah, you know, from something simple like that the scleral lens is treating the allergy, and sometimes there isn't allergy and people just get keratoconus. Sometimes they have systemic problems. Then we can see where the patient is. We can use machines. The machines are very advanced now. We can map out what's the problem, and then we can help. Early is always better. It's always better to catch it early, treat it early, rather than late. Yeah.
Oh, wow. Okay, so rather catch it early rather than late.
Yes.
Thank you so much, Dr. Mofokeng. It's been a pleasure to have you.
Thank you. Thank you so much for having me, Dr. Tibbs.
And to the viewers back home, thank you so much for listening in about keratoconus. If you'd like more information about this, please leave your questions in the comments below, and we'll get back to you about them. And also, please don't forget to like, share, and subscribe, and push the notification button so you know when we post a new episode. And please don't forget to follow us on Facebook and on our Instagram pages on the Dr. Tibbs Show for more, inputs during the week. And yeah, until next time, take care of yourself, take care of each other, and remember, your health is in your hands. God bless.